Okay, we should be going live. Okay. Hello, everyone. Welcome, welcome, welcome. Hello. Welcome to Q&A with Dr. Mercy. Let me see. We'll wait and see if people are online. Hello. I know it's been a long time. Let's see. Hi, everyone. Hi. Welcome, welcome to Q&A with Dr. Mercy. I know it's been a long time, but I'm glad to be back. If you guys can type where you are seeing this from, what location you're at, I would greatly appreciate it. Welcome. Happy Friday. Happy Friday evening for those of you who are in the United States. This is going to be a very good talk. We're going to be talking about the number one cause of blindness, especially in the Black community. And I have here with us an optometrist who will let us know this type of condition and what some of the things we should do in terms of preventing or even treatment of this condition. So where are you guys watching our show from? Oh, Carol. Hello from Rio de Janeiro, Brazil. Wow. Hello. New Jersey, Dr. Princess. Hi. Chicago, Andrea. Hi. Welcome. Welcome. Barbara, California. Wow. Port St. Lucius, Florida. Awesome. Georgia. Arlington, Texas. I'm nearby in Houston. Hi, India. Welcome. Trinidad and Tobago. Awesome. Wow, there's a lot of us here. Welcome, welcome, welcome. So a lot of you are probably wondering, like, where have you been? Well, I've been literally around Africa. Shortly after I did stopped my last session, I did a medical mission trip in Nigeria. Wonderful experience. This is actually where I met our wonderful optometrist, Dr. Cece Onyenekwu, who is going to be talking to us about the number one cause of blindness. And after that, I've been very busy on other nonprofit organizations, but I've been missing you guys. And I'm like, let's discuss all the medical topics that affect our community. And so I decided, it's time to come back. So I'm happy to be back. Well, welcome all of you to this wonderful show. Like I said, it's going to be a goodie. We're going to be talking about the number one cause of blindness in our community, the Black community, as well as those who are over 60 years old. But before we do, let me introduce our guest, Dr. Cece Onyenekwu, and I hope I'm saying her name right. She is an optometrist practicing in the great state of New York. So let me bring her in just a moment, you guys, and welcome her to our show.
Hi, hello everyone. Hello, Dr. Mercy. Thank you for having me. So,
hi,
hi, sweetie. How are you? I'm so happy to be here. I think
well.
there's a little lag.
You? I know there seems to be. So one of the first questions that I do have is, I know this question, but I know the answer to this question, but I know a lot of our guests, they may not know. What is the difference between an ophthalmologist and optometrist? Aren't they both eye doctors?
You are correct. They are both eye doctors. Ophthalmologists are medical doctors that go through medical school and then do a specialization in the eye, where optometrists are doctors of optometry who spend 4 years focused on the eye. Optometrists treat and manage ocular disease and refract. Optometrists do not do surgeries in most states. Some states allow some laser surgeries and minor eye surgeries to optometry licensures. But for the most part, when you think about cataract surgery or, those surgeries are done by ophthalmologists, medical doctors, and doctors of optometry treat and manage eye disease like glaucoma, red eyes, and we're going to refract for glasses and contacts. Okay.
Awesome.
So that's basically the difference between a doctor of optometry and an ophthalmologist.
So it looks like someone already knows you in the chats. She says,
Hey,
"Hi, Cece.
Ashley.
We went to Dillard's together."
DU. That's so
Awesome.
funny.
So great. Okay, so those are the difference between an optometrist and an ophthalmologist. And you're an optometrist practicing in the great state of New York.
Correct.
Thank you so much for coming to our show and to let us know more about the number one condition that causes blindness in our community, especially with those over 60. The condition I'm talking about is glaucoma. I saw a lot of glaucoma in Africa, in Nigeria.
Yeah, it's
Why
an
do you think there's
epidemic,
such a
unfortunately.
prevalent case? I know.
So, to get into studies, it's just something that's more peculiar to African and Black people.
Mhm.
It's at a higher incidence, even though white people do suffer from glaucoma as well. Okay, so
Mhm.
what is glaucoma? Glaucoma is a disease of the optic nerve. Okay, in the back of your eye, in the retina, we have a structure called the optic nerve. The optic nerve sends visual information to the brain so that we can see. Okay. So your macula controls your central vision, your optic nerve controls what we call our peripheral vision. And so what happens in
Okay.
glaucoma, you're sensitive to your natural eye pressure, whatever pressure that you present with, and that pressure causes an enlarging of the optic nerve. So when I say it causes
Okay.
an enlarging of the optic nerve, the optic nerve is kind of shaped like a donut. So think about the whole of the donut. If that and the meat of the donut or the dough of the donut is your outside vision or peripheral vision. So you're
Mhm.
sensitive to your natural eye pressure. It's weighing on that nerve and causing atrophy of the cells, and it
Mhm.
causes enlarging of that nerve. But when you lose that rim tissue or the dough of the donut and that hole in the middle gets bigger, that is your peripheral vision. So you really
Mhm.
don't want to wait till you notice vision loss. That's end stage glaucoma by the time you notice, because usually it affects one eye more than the other eye, then it goes to the other eye. Okay.
Mhm.
So what is best practice is, even if you see a perfect 20/20, get an eye exam every 1 or 2 years, and make sure you're getting an eye exam by a reputable person who's checking not only, you know, for glasses and contacts, but checking the health of your eye. We cannot
Mhm.
divorce ocular health from a refraction of getting glasses and contacts. So,
So let me get that straight. So just to recap what you said,
yeah.
glaucoma is when you have increased pressure inside your eyeballs. Okay, so if you see your eyeballs, it's kind of like a ball, right? And at the back of your eyeballs, there's this nerve that's called the optic nerve that's connected to it. So are you saying that if you have increased pressure inside the eye, it kind of causes damage to that nerve at the back
Yes,
of
and
your eye?
we move away from talking about increased pressure because there are normal tension glaucomas. So
Okay,
we like pressure to be between 10 and 22. And everything
okay,
above 22 we consider ocular hypertension. Those are easier glaucomas to catch because those pressures are outside of what we call normal range. But what they've moved
okay.
to say now is pressure that you are sensitive to. Because if you have a pressure of
Okay.
18 and it's causing glaucomatous changes, that's glaucoma. It might not necessarily be high eye pressure, but correct.
High eye
That
pressure.
pressure is affecting your optic nerve. And
Okay,
yeah.
okay. So what are I read somewhere that there's different types, and this is what you're alluding to, the different types of glaucoma. There
Yeah.
is, the acute, meaning it
Hmm.
happens all of a sudden,
Hmm.
whereas maybe the more slowly happening chronic glaucoma. There's
Hmm.
different types. Can you explain the different types and what we should look for, uh, to what conditions or what symptoms we should look for if we were to experience these conditions in our eyes?
Okay, so there are major types of glaucoma. You have an open angle glaucoma, angle closure
Mhm,
glaucomas, congenital glaucomas,
mhm,
and secondary glaucomas. And
mhm,
majority, I will say, are open angle glaucomas. So to understand that, imagine fluid. Your eye is a globe, and fluid
mhm,
is in the eye, and it creates a pressure gradient. So fluid is produced in the eye, aqueous humor, and it exits the eye through an angle. Okay. So production and exit of a fluid creates a pressure gradient. Okay. So when you have, let's say, acute angle closure glaucoma, that means the angle has closed in the eye for some reason, and the pressure goes up really, really high. And so we have to open up that angle and then get the pressure down really quickly before it snuffs out vision in the eye. So people who experience angle closure glaucoma are probably the ones that are going to feel a symptom. They're going to feel acute eye pain. Okay. Those ones, you go to the emergency room there, and yeah, you're in the ER. So those are the cases that you see most often when it comes, right?
Right.
Can I ask, what do you
I'm
do when you
actually
see those
upstairs.
patients?
I'm not in the ER, but
Oh, I know, because
yes.
you're in Mercy. Remind me.
Hospital. I'm hospitalist.
Okay, hospitalist.
So
Okay,
I admit the patients
okay,
to the
after
hospital.
they've been treated in the ER.
Yes.
Okay.
So a lot of times those acute glaucoma patients, the ER doctors handle quickly and refer to you guys for further management. But yes.
So those okay. So that's acute acute angle closure glaucoma. Okay. Then there's open angle glaucomas, which are the most common. So these are the ones where, again, your pressure, the angle is open. So there's production of fluid and exit of fluid out of the eye. Nothing is inhibiting fluid from exiting the eye. However, that pressure that you have is causing an enlarging of the optic nerve, the enlarging of the optic nerve. Okay. So those there's various treatments. Those ones are the most insidious because you're not going to feel a symptom, okay? By the time you notice, because if you imagine each eye is seeing the same image, and so there might be a piece of vision loss in one eye, but your other eye is compensating for it. It's not until there's progressive damage in one eye and then in the other eye in the same spot that you'll notice a piece of your vision is missing. We don't want to wait. In this day and age of technology, we do not want to wait till we notice symptoms. This is why it's important for everybody, even if you feel like you see a perfect 20/20, it's not about 20/20 vision. Get your eyes checked, especially if you have a family history of glaucoma, especially if you have a sibling who has glaucoma. These are people that your due diligence to yourself is to get an eye exam, whether you need glasses or not, because I feel a lot of times people come in for eye exams because they need glasses or they need contacts. They can't see. They don't. And if they can see, they don't feel like they need an eye exam. But you're not going to notice changes from glaucoma until it's end stage. So we don't want to notice changes. We want to intercept before there's any change in your visual field. We have plenty of treatment options. So it's not something, a lot of times people are afraid to come in to get a diagnosis, but this is treatable. And the earlier that we can intervene, the better. Okay. Because vision that you've lost is lost forever, but we can preserve what you have. Okay. So it's always good to come in and get an eye exam.
So what I learned from what you said is, one, if you have eye pain, a lot of eye pain, like sustainable eye pain, go get it checked, because especially that could be the acute glaucoma that is developing. And so make sure you get it checked. And then if you have a family history of glaucoma, you want to get your eyes checked, because there is a strong correlation, or you have a strong risk factor of you yourself getting glaucoma. And by the time you notice the glaucoma, you've already lost a lot of vision. And so it's better to get treated early to prevent vision loss than to wait until it occurs. Because in glaucoma, can you reverse the changes?
We cannot. What you've lost is lost. Okay. So the sooner that we intervene and get the pressures down, the better. Okay. So it's not to be avoided. It's to be embraced. It's to be leaned into, because you don't want to wait till you've noticed a change. We can't bring back what you've lost. Okay. So my biggest recommendation is anybody that you know that's Black, and not even that's Black, yes, but even anybody you know, if you've get an eye exam, I always encourage people to be ambassadors. Bring a friend. Like when you're going to church, you want to bring them. It's like sharing the gospel. Come and get an eye exam. Have you got an eye exam? I just got an eye exam. It's so easy. Come and share the gospel with everybody. Tell them how important it is to get an eye exam. And just knowing is better than not knowing. So I encourage everybody, go and get an eye exam, okay? And by a
Right.
reputable source. Make sure that the questions to ask are they taking retinal photos? Are they doing a visual field? If you're ask what your pressures are. Are you a glaucoma suspect? If you're a glaucoma suspect, but they don't want to treat, you should be seen every 6 months to 1 year. Like, just ask questions about, even if you just prod and say, are you doing a glaucoma is a part of my exam, a glaucoma evaluation? We have so much technology to follow glaucoma patients. In America, I don't know if everybody's on this form in the United States, but
not everybody is not. No.
Okay.
But
Okay.
in the United States.
In the United States, what I saw on that medical mission trip is we are very blessed in the United States to have all this technology. So every American, go get an eye exam. If you're not an American, get an eye exam. There are no excuses. Go get an eye exam, okay? Because even if somebody just looks inside your eye, we can treat prophylactically just based off how your nerves look, okay? So.
And I would equate this. I know, you said that there's different types of glaucoma. Not every glaucoma is due to elevated pressures in your eyes, but I want to say that this is very similar to high blood pressure, in that high blood pressure is what they call a silent killer. You'll have high blood pressure and you wouldn't know. You'll be walking around with high blood pressure. The only time you would maybe know is if you start getting headaches or blurry vision. That's when you start noticing it. And by the time, it may be a ticking time bomb before you have a stroke or you have a heart attack. So that's why it's always, always, always good just to have your annual visits to the doctor, your medical doctor, and also to an eye doctor. Just go in there, get it checked, see what your pressures are. Make sure, like you said, that they do imaging, that they can look at the back of where your nerve is at the back. Make sure it looks good so you can have peace. It is knowledge is always power.
Yes, I agree. Yes. And I would also like to say that there are retail settings that will say, will offer the refraction for glasses and contacts and allow you to opt out of the retinal photo. I would, if you want to do a thorough job, make sure they're taking pictures of the inside of your eye. That's the best way. We just need to look at the nerve. Okay. So don't opt out of those, that aspect of the exam. If you go to retail locations like the America's Best, Vision Works, Luxottica's, some of them, not all, most of those locations are doing it as a part of their routine eye exam regardless. But let's say you go to a private practice. So retail locations actually aren't really they're not the issue. It's sometimes the private practices as well. They'll let you opt out of the retinal exam. Don't opt out. If it's a dilation that they require, if it's a picture that they want to take and it's $10 more, go ahead and do it. Most insurances cover these comprehensive eye exams. And just your due diligence is just to say, is a part of this eye exam, is it a glaucoma evaluation? And majority of eye exams are, okay?
So, what is this? How does the eye look in the severe stage of glaucoma? You can tell.
I wish I could show my screen. Is there a way to share my screen?
Share. I think you
can. I
can.
can. Okay. I will pull up a picture. Let me see. Let me see if I can pull up a picture of a normal optic nerve versus glaucoma. Okay. So this is, I'm going to share.
You guys, if you guys have any questions, please put in the comment section. Cece, call her. We'll be happy to answer your questions in dealing with glaucoma and with eye issues. So if you have any, make sure to put it in the comment section.
Okay, so this is window. How do I do this? Chrome tab, window. How do I, I'm not good at this. I'm going to share entire screen. Share.
Okay, that's fine.
Okay, so what normal, okay. So this is a picture of, let's see, I can go here. Okay, so let's say, okay, this is, can you see my mouse? moving?
No, we can't see your screen. I don't still just see you.
Oh, really? Chrome has last permission to capture your screen. To fix it, go to unlock the screen. Girl, I don't know how to do that. So, oops. Mercy, where are you? Oh my God, I lost you. Leave. There we go. Mercy, I'm in the show, but I don't see you. Okay. There we go. I apologize.
I think we had some technical issues. Sorry about that.
Yes.
Everyone, technical issues. So it looks like we won't be able to show the photograph, but if we maybe describe it, that'd probably be good too.
So, and can I say something? I think it's less important how the nerve looks because you're not going to be able to visualize your nerve. I think what's important is to know that it's something that deserves early detection. And the only way to get early detection is for you to go to an eye care practitioner and take a retinal photo of your eye, do a test called a visual field, have your pressures taken at the baseline. Okay, there are other more detailed tests like OCT of the nerve, and then there's a test that measures the thickness of your ganglion cell layer. That is a new innovation. We've had that technology, but what we're finding is that even we can detect early stages of retinal thinning with that GCC, and so we can treat even earlier, even when we don't see so many signs at the nerve or at the visual field. Okay, because we can have thinning of the retina, thinning of the nerve, and before we get a visual field or a change in your peripheral vision that's noticeable. Okay, so and how do we treat? Dr. Mercy, I'm just talking. Interrupt me at any point in time. Okay, so how do we treat? Treatment is very straightforward. We use eye drops to lower the eye pressure. We have different types of drops. We have lasers that we can treat to replace an eye drop. Okay, there are glaucoma valve surgeries that we use to help decrease aqueous production. So there are several treatment modalities available to us. So glaucoma is very treatable. We just need to know you have it to treat it. So that's where it's your due diligence as a community to just make sure that you're getting your eyes examined regularly and to follow up if you're listed as what we call a glaucoma suspect. Okay. There are some people that their nerves are suspicious, and we like to follow those people. For example, people who are nearsighted. Nearsighted means you can see up close, far away is blurry. A nearsighted person tends to have a larger eye, and so you're naturally going to have a larger nerve. Okay, those people, they have a large nerve, but their pressures are not causing the enlarged nerve. They naturally have a large nerve. For example, I'm 6'2". That's natural for me in the context of my family, my genetics. Some people just naturally have large nerves. They don't necessarily have glaucoma. So we put those people in categories called glaucoma suspects. And glaucoma is a progressive disease. That means it changes over time. If you're naturally nearsighted and you have a large eye, you're myopic, that is not progressive. That is your physiologically how you present. So if we check you every year and it's not changing, then we can say with confidence, okay, that's just the way you are. Okay. But you still get put in this category of it's either you're normal, you're a glaucoma suspect, you have glaucoma. So if you're normal, hi, great. Here's your, see you next year. Glaucoma suspect, let's watch you. If we're going to create an eye story. We see you in 2022, 2023, 2024. The more information, the better. We have information. We can say this nerve looks the same in 2022 compared to 2032. This is physiologic cupping. There's nothing going on with this patient. See you back next year for your glasses and or contacts. Okay, so is your due diligence, the due diligence of the average person is just to show up and get an eye exam. They're not painful. You go in, nobody loves the puff test. There's different ways to take your eye pressure. Most people know about the puff test. Model Lewis, Miss Lewis. Yes, I get my exam every year, 81 years old. Beautiful. I love to see it. And I hope you bring somebody with you when you go, Miss Lewis. And Dr. Mercer, you sent me some questions.
It'd be nice if they do some glaucoma screening in our community, just like they do blood pressure screening. It'd be nice to have glaucoma screening so that we're all able to.
That's a great idea. Glaucoma screenings. I have an eye care tonometer here. If you ever want to collaborate and do a glaucoma screening, we just get a direct ophthalmoscope. It's very straightforward. Get a direct ophthalmoscope, check pressure. Set up a visual field. That's something that we can easily do. I would love to be a part of glaucoma screenings.
That would be nice.
Yeah.
Dr. Stella Morafa has said, I believe answered this question, but she said, causes glaucoma and what impact does diabetes have on it?
Okay, so glaucoma, nobody's really sure of the cause. We just know what happened, what the that if we lower the eye pressure, that it affects it. We don't get this change. Okay, there's a lot of studies about the cause, but we just know eye pressure. We don't know why eye pressure is affecting the nerve in this way, but we just know that certain eye pressures in certain people causes change in the nerve. And that we know, imagine a weight is on that nerve, okay? And that's your eye pressure, and you're sensitive to it, and you can't withstand that weight. So it causes atrophy of the cells in the optic nerve, okay? So when we lower that eye pressure, it's reducing the stress on that nerve, and then you don't get those glaucomatous changes or enlarging of the hole. Remember, the nerve looks like a donut, so enlarging of the hole of the donut, okay? We don't get that enlarging. And what impact does this diabetes have on it? These studies will say diabetes and high blood pressure is a risk factor. But my opinion is people who are diabetic and have high blood pressure are a captured community that is going to, if your eye doc, your endocrinologist or your primary care doctor who's treating you, your internal medicine doctor is going to refer you for an eye exam. So this is a population that is caught more often than, let's say, somebody who does not have diabetes and high blood pressure. So sometimes I question when they say diabetes and high blood pressure is a risk factor. I think those people are being seen more often than the healthy patient, systemically healthy patient. So that's my answer, Dr. Marafa.
Well, I have a couple of questions. So let's say someone gets diagnosed with glaucoma. Is there any impact with exercise? Should they limit certain exercises? or should they even go on planes? Because high pressure, planes, or you're above ground, does that affect anything?
No, there's exfoliative glaucoma. So the glaucoma that is affected by exercise is one exfoliative glaucoma where stuff is in your eyes. So you know what? I want to explain this right. So I'm gonna cheat so I can explain because there's pigmentary glaucomas and exfoliative glaucoma. So pigment and will get in the angle. Remember I said there's production. Yeah. So things that compromise the angle. So we were talking about the types of glaucomas, right? So you have open angle glaucoma, which means that there is nothing obstructing the angle and it's just your eye pressure. But then there are situations.
About angle, just to make sure that they understand, the angle is in the front of the eye, correct? The angle
is what?
Is in the front of the eye.
Yeah.
Where is the angle located? It's in the front of the eye, right? And
yes,
it is that area that kind of connects the front and the back a little bit. Is how would you describe that?
Okay, so we're
nice to have a picture.
I know. It's just I could try again, but I'm afraid to share my screen.
Yeah.
I don't know how to share my screen. Okay, so you have your pupil is created by your iris. Okay, there's a hole. Okay, so that angle, that pupil is at a plane like this. The iris is at a plane like this. And you have
your eyes. You have blue eyes, right? If you have blue eyes, blue that is blue, green that blue, the iris itself. Go ahead.
Very good. And then how can I do this? If this is my hand, this is the angle. Okay. This is the angle where fluid exits the eye. So fluid is produced here at the ciliary body. Okay. Then this is right here. Let me see. Then you have your lens. This is so sad. You have your lens. Behind your pupil is a lens, your crystalline lens. Okay. So it travels around that lens through the pupil. So this is your iris. This is your iris. This is your cornea. And there's an angle where fluid exits, through the trabecular.
So there's fluid. So in the front of your eye, there's like a little chamber where there's fluid. And then you also have fluid in the back of your eye. And somehow they connect. Okay.
It's all connected.
It's all connected, like kind of like a circuit.
Circle, yes.
Mm-hmm. Yeah, or circle. The problem happens in glaucoma is when this
angle
the connection from
So if this angle gets closed, that causes acute angle closure glaucoma. Sometimes your crystalline lens is too bulbous, like hyperopes. The lens is bulbous, so it'll destroy. It's everything's so tight in that space, so it'll push and it'll close. Okay. Then there's exfoliative and pigmentary glaucomas, which exfoliation is like stuff from the strings from the ciliary body will get stuck in there. Okay. Or I don't want to explain that wrong. Y'all have it. I refer the exfoliative glaucomas.
No, I think we get it. I think what it is that, like you said, it's when the front of the eye and the back of the eye, the fluid in the front of the eye and the back of the eye is not communicating because there's something is blocking it. So when that
fluid
happens,
cannot
that's
exit
when
the eye. That pressure goes up. Okay.
Yeah.
So those require treatment. Okay. To restore back memory after 2 months.
That's awesome.
Okay. So I'm trying to read some of these comments. And somebody's writing some love story.
Thank you for sharing. I believe Mr. Greg B said, thank you for sharing. I believe his wife, his ex-wife went blind with glaucoma and she had diabetes. So
Okay.
Mr. Greg B had talked about that. So this is, he understands the value of this talk because he knew
Yeah.
someone, his wife, who had glaucoma and diabetes.
Does she have diabetic retinopathy as well? Was it a combination of, did the diabetes cause, because there are neovascular glaucomas as well. So untreated, so glaucoma is related to, thank God. I'm so happy to hear that, Mr. Greg, that your glaucoma is under control. So glaucoma does have a relationship with diabetes in that if you're walking helps reduce pressure. Although walking might help reduce eye pressure, it's not the most efficacious treatment. So we want to use eye drops. Okay, I'm happy that you brought that up because, there's a lot of conversation around weed. Weed does bring down your eye pressure. However, weed is not a treatment because there's a word called efficacy. We have a targeted goal, and the amount of weed that we would have to use to bring down pressure constantly all day long is not efficacious. It's too much. We have eye drops that do the job of bringing down eye pressure the way it's going to, the schedule that we need to bring it down and stay down all day long. The idea is every day, we don't want your pressure to live up here. We want it to be here. And so we have drops, well-studied drops that work, that bring your eye pressure down. We set targeted goals for eye pressure. If we can't get there with one drop, we might add another drop. If we can't get down there with 2 drops, we might add a laser and use an eye drop. We have so many ways. We have a box of magic tricks of ways to set a target pressure and then go about trying to achieve that goal of your targeted eye pressure. Okay.
And just in case there's any confusion, let me ask this question, Dr. Cece. You taking let's say your doctor prescribes you eye drops for glaucoma. Does that mean that it's just a 4 to 6 week treatment, or is it going to be chronic? What usually happens with glaucoma and treatment? Is this a long stay thing, or once you're done with the eye drops, you're pretty much cured?
Good question. And that's the best question of the evening. Once you start eye drops, it's the rest of your life. So this is why we want to be sure when we make these diagnoses. And this is your due diligence is to show up at the schedule in which your doctor is treating you. Again, that recommends. Again, it is a progressive disorder. So if you're a glaucoma suspect, maybe there's not enough damage on day 1 and they don't want to commit, or it's your borderline. So we say, let's see you in 6 months. It's important. I know we're all busy. Clear the day if it takes if your office, the office that you go to takes a while to commit to whatever schedule your doctor wants to see you. It might take. What we want is repeatable information. So you might take a visual field on day 1. We're not going to go by that visual field. A lot of times people are tired, right, dry eyes. A lot of things can affect these tests that are outliers. So what we look for is repeatability. So we want 3 or 4 visual fields before we make a decision, because you're right. Dr. Mercy, when you start the eye drops, it's for the rest of your life. So these are diagnoses that we want to make with full confidence. I can say with confidence, you have glaucoma. I don't want you to be a glaucoma suspect. Some people who have ocular hypertension, whose pressures live above 22, some of us will decide to just prophylactically bring the pressure down because we know what the studies say about ocular hypertension. Okay, so, but you definitely deserve to be watched if you're again, it's a combination of looking at the optic nerve. Some people have ocular hypertension, but their nerves look very healthy. They don't look large. I see those people once a year. Some people have medium-sized nerves, ocular hypertension, full visual field. I might see that person every 6 months. Some people you see every 3 months. It just depends on your presentation. Okay. Is gel detachment from the retina dangerous? Gel detachment or retinal vitreous gel, like vitreous humor? I need details, Miss Yinka.
Okay. Like is any detachment
like vitreous detachment?
I guess there's usually the retina is the one that gets detached, right? Or the vitreous humor The vitreous.
Yeah, no, there's posterior vitreous detachments, PVDs, which is like a large floater. Floaters by themselves are fine. Okay, it's when a floater is associated with a hole or tear of the retina that could lead to a tear of retinal. That is a cause of concern. A lot of people have floaters. Okay, it's floaters. What is a floater? A floater is the eye is kept around by a clear jello-like substance called the vitreous humor. That humor will liquefy as we get older, or if you're very nearsighted, it liquefies earlier, and you'll see floaters in your vision. 1 or 2 floaters that come and go, normal. But any new floater deserves a dilation. We want to make sure when that floater liquefies, sometimes it can tug on the back of the eye, the retina, and cause a retinal detachment or lead to a retinal detachment. It causes a small retinal hole or tear, and that can lead to a retinal detachment. So any new floater deserves a dilation or an optos, any ultra wide field view of the retina. We want to view the retina in its entirety once we see a new floater. So Miss Yinke, yes, PVD, posterior vitreous detachment, by themselves, we don't do anything about them. Okay, but we do want to dilate and make sure it's not associated with any hole or tear of the retina.
Okay? How frequently should she go see the optometrist or ophthalmologist if she's been diagnosed with something like that?
PVD, when you first see a floater or notice a floater, you come in, you're dilated, and then we like to dilate a month from that date again, okay, just to make sure nothing develops after that, and then you're followed yearly, okay?
Yearly.
So,
okay.
PD, and I will say this, I'm an optometrist, and I feel I'm happy to be here because a lot of people feel like ophthalmology is the only one that can give information about ocular health. And there are a lot of ophthalmologists and optometrists that are not focusing on full scope ocular care. But an optometrist can dilate you and take a look and tell you, okay, your PVD that's a PVD, that's a large floater. It's not, there's no hole or tear associated with it. I'll see you back in a month and I'll dilate you again. And if they see a hole or tear, they can refer you to a retinal specialist for treatment. Okay, so that's a great question. Reiki self-treatment helps. Mr. Greg, I'm not going to discount you. I believe in evidence-based medicine, so that is outside my scope of practice. And I haven't done enough research about Reiki self-treatment, so I have no comment on that. Okay, I know. Okay. So, and then Ms. McMillan.
So a lot of times alternative medicine can help, but unfortunately it doesn't, we don't see established research articles, which we call evidence-based medicine, that collaborates with the alternative medicine. So further research, further studies have to be done in order to now validate what is being seen in practice, Mr. Greg. So yes, it may work for you, but you have to have further studies to make sure it works for the whole community, the whole world, to now say, yes, this is a treatment for this particular condition.
Thank you. Yeah, Dr. Mercy. And then Ms. McMillan, I'm 61 and was diagnosed with glaucoma at 19. I've lost vision in my right eye. I'm sorry about that. Due to the nerve damage. I am on Combigan, Good, and Rocklatan. Unfortunately, I'm not the only one in my family with it. My concern is that I haven't passed this nasty disease to my sons. Yes, I'm going to have them tested for the gene. Absolutely. Good. So, Ms. McMillan, all you can do is have them tested. And since so Ms. McMillan, you're worried about your sons, good, but also, do you have siblings that have you would want to make sure all of your siblings are getting tested as well, okay? And obviously your sons, because they do have a family history, but the risk factor is increased across siblings and then still is a risk factor within families, okay? So definitely have them, and it's as simple as taking a picture of the nerve. It's a disease of the optic nerve. So all we have to do is lay eyes on that nerve. We have retinal photos. The retina is the thin layer behind your eye, and it houses the optic nerve that controls your peripheral vision and your maculas that control your central vision. So we need a visual of that posterior pole right behind your pupil. That's where your optic nerve lies, and we just need a picture. So for all your sons, definitely, it's not something to lean back. We want to lean in. We don't avoid the diagnosis. We want to know as soon as possible because this is very treatable. We have the technology to monitor progression, and we have the means to treat glaucoma. Okay.
Yeah.
And Miss McMillan, two sisters as well. Okay, good.
Yeah.
And I'm hoping that they're using their eye drops.
So, Mr. Greg, I also agree with you. We need more research, especially in the alternative medicine realm. And thank you for respecting our answers. We respect your comments as well. So yes, more research should be done. I also agree with you because there's a lot of benefit in alternative medicine. So thank you so much with that. Thank you so much, Dr. Cece, for coming on this Q&A with Dr. Mercy. I know this is just the beginning, and you'll be coming on and telling us more about eye care because that's so important. Vision is just so important, and so I'm not going to say, I'm going to say until next time
thank you
you'll
for
come
having
in
me.
and tell us more about it.
Okay, wonderful. Thank you for having me. Sorry for talking so much, but what you're doing is amazing, Dr. Mercy. I love this platform. I'm so grateful and happy to be a part of it. Thank you for having me on.
Oh, thank you. And thank you, audience, for coming on. I will try to be coming on Fridays as well. Same time, same place. We'll still be doing more Q&A with Dr. Mercy with other topics, including eye care. We'll be coming on board with also other specialists. I'm trying to get Dr. Gertie, the infectious disease specialist, to come on board so she can talk more about monkeypox and COVID and things of that nature. So thank you guys. Have a good night. And until next time, bye.
Bye, y'all.